this meeting. It's the October 1st statewide collaborative meeting. And I do want to go through, and I know we have several people online excited to hear our presentation today from NCOA. So I'm flying solo today. We have our big annual fundraiser today, so I'm going to also be leading the call myself at about 10. Lindsay will make sure we stop recording and close out the last part of the meeting, but we are going to start with our guest speakers today in courtesy of them being here. And I'm going to do some roll call, and then I'm going to ask Connie to introduce our presenters. So let me just look at who I think is on the call. So it looks like I have Kelly McCracken, and you might introduce yourself and who you represent.
Sure. Hi, this is Kelly McCracken. I'm with the Colorado Department of Public Health and Environment. Thank you.
Thanks, Kelly. Ellen Pilstrom.
Hi, this is Ellen, and I work for University of Colorado Health in the Larimer County area.
Thank you. Samantha Decker. Samantha, are you on the call? Okay, let me move on. Whitney.
Hi, this is Whitney Jansen-Pancratz from Weld County Area Agency on Aging.
Hello, Whitney. Let's see. I've got Connie Young, of course.
Yes, I'm here with the Colorado Department of Human Services.
Thank you. Now, I see there are several other attendees, but your names aren't coming up. Let me just see if I can scroll down. Wait, there we go. Okay. Teresa Arney?
Yes, I'm here.
And where are you from?
Oh, I'm sorry. Administration on Aging, Administration for Community Living.
Great. Well, welcome. And you are calling from what area?
Washington, D.C.
She's our grant coordinator in D.C.
Great. No, that's why I wanted to be sure we drew attention to that. And then Michelle Bota.
Hi, I also work at Administration on Aging at the Administration for Community Living, and I'm currently the team lead for the Chronic Disease Self-Management Grant Program. So this is the first time that NCOA has pulled all this great information together, and so I'm just going to be listening in.
Great. Well, we're glad to have you. Hi, Michelle.
Hello.
And I'm going to go to Crystal Ryder.
My name's Crystal Ryder. I'm with the Southeastern Colorado AHEC. And I'm going to have to jump off the call in about 15 or 20 minutes. I'll listen to the recording.
All right. Yes, thank you.
Thanks.
Maria Lopez.
Hi, this is Maria Lopez with Clinica Tepeyac in the Globeville area, Swansea area.
Welcome, Maria. Did I get everybody? Samantha Decker, are you on?
Here's Glenda Mitchell from the Center for African American Health in Denver.
Great, thank you, Glenda. And it looks like Samantha's on. She may not have audio, so. And Samantha's with the Tri-County Health, I believe.
Yes.
In the Denver area. And then, of course, we have our guests on the line as well, Cora Plast and Mary Walsh. So I'm going to hand this over to Connie and let her introduce our guest.
Great, thank you. And I really appreciate everybody being here. As we said, Cora has to sign off shortly, so I will introduce her first. Cora Plast is a Senior Director of the National Chronic Disease Self-Management Education Resource Center with the National Council on Aging, and she provides oversight and resource for the center, and it's as some of you probably know, it's a national clearinghouse for chronic disease self-management education, a great resource. I have to say, I never say enough about all the great resources that they have online, as well as the assistance that both Cora and Mary have provided over the years. Cora also has more than 30 years of experience in aging and public health. She was previously the director of the Division of Healthy Aging at the South Carolina Department of Health and Environmental Control. She has a master's degree in social work and is licensed as an advanced practice and clinical practice independent social worker in South Carolina. And Mary Walsh is also with the National Council on Aging, and she has worked there for 5 years as a senior program manager and later as a consultant. Before joining NCOA, she worked at the Office of Elder Services in the Maine Department of Maine, State of Maine, that is Maine with an E, Department of Health and Human Services for 25 years. She has a bachelor's degree from Case Western Reserve University and a master's degree in education from Northeastern University. So Cora and Mary are, at least probably Mary primarily will be the presenter, but they're the provided the slides that we'll see shortly. And then we also have two guests who may not be making comments, but will be listening in. They're both from U.S. Health and Human Services with the Administration on Aging and Administration for Community Living, and they have worked with us over the last 3 years on the grant. Michelle Buta is the well, I already said where they are. She's the team lead, as she said a minute ago, for the Chronic Disease Self-Management Education Program grants. She previously coordinated evidence-based self-management and physical activity programs at the Arthritis Foundation National Office, and she worked as a state hemophilia at a state hemophilia foundation on diabetes research and education project, and as a volunteer nurse in Vietnam. She has a Bachelor of Science in Nursing and a Master's in Public Health. And Teresa Arney is the Aging Services Program Specialist who's been my primary contact point for the past 3 years on the grant. And she has a wealth of experience in social service, education, information education, and real estate. And she used to run the library for what was the National Information Center, which, let's see, I'm trying to reread this, and then eventually closed the library, but she since dedicated the past 10 years working initially as a project officer with evidence-based programs and with Alzheimer's and related disease, and more recently with the Chronic Disease Self-Management Program. So we're really fortunate to have all four of these people making themselves available for this call and doing an extensive presentation for us. And I mentioned before on our call that I thought it would be helpful. They've offered in the past to provide technical assistance to us, and we talked about some of the ways they could do that. And one of the topics that seemed most timely and valuable to us in Colorado would be for them to inform us as to strategies that they think are most beneficial as far as sustaining CDSMP long-term, and some examples of what other states have done that have been successful. So with that, I will let Mary, I guess, take it from here.
Okay, thank you, Connie, for that nice introduction. You can go to the next slide. And the next one, please. First, I'd like to introduce the National Council on Aging to you a little bit. It's a nonprofit service and advocacy organization that's based out of Washington, D.C. Next slide. National Council on Aging, we are the resource center for CDSME grantees from both 2012 and also the new grantees that just started in September for 2015. In addition to that, we're the National Resource Center for the Falls Prevention Grants programs, and we offer technical assistance to other states as well, states that are offering chronic disease self-management education. Some of the things we do as a resource center are we provide webinars, newsletters, we contribute to publications, we put out tip sheets, we have an online community, and many other things. And we're going to be talking a little bit more about our other resources later in the presentation. Next slide, please. Slide, please.
Okay.
The next slide.
Yeah, I'm trying.
Oh, okay.
There we go.
Okay, that's the one. We're going to be talking today about sustainability, and we're going to frame our discussion around these 6 sustainability components. Our plan is to talk for about 30 minutes or so and then have some time for networking and questions. Next slide. The first element of sustainability is effective leadership. And among other things, effective leadership can bring together different partners. It can provide the infrastructure. It can provide the Stanford license. And effective leadership helps plan for the future of CDSME. Next slide. For the 2012 grantees, some of the lead grantees were departments of aging and some were public health. In either case, they were charged with working together to bring CDSME to older adults and people with disabilities in the state. That collaborative leadership is really very helpful because it builds on the common goals of public health and aging, and it also melts the strengths that the 2 different departments bring to this program. Because of the joint collaboration, funds can be leveraged both from CDC and also from aging. For public health, there are a number of different funds that can be leveraged, and on the aging side, there's Title IIID and some of the other Older Americans Act programs. Because the 2 organizations are working together, they can engage a wider variety of community partners, and they can reach more underserved areas and underserved populations. It's also important to recognize that district and regional public health offices can be very helpful in terms of funding and sometimes implementation sites or reaching older adults and people with disabilities. Next slide. Talking about the effective leadership, there are some really good models, and I'd just like to talk about a few of them. In Massachusetts, Public Health is a Prevention and Wellness Trust Fund, and all the partners in that fund will integrate CDSMP into their existing program delivery infrastructure. And in some states like Rhode Island is working very closely between public health and aging. They're coordinating with their 1305 funding, also arthritis and wise women. To make certain that the evidence-based programs are as accessible as prescription medications, which is one of the things we're charged with, we need to have a delivery infrastructure that can reach all older adults and people with disabilities who are targeted by the program. Next slide. Having a good delivery system statewide is really important, especially as states are working towards more of a statewide approach and also working with healthcare providers. Because healthcare delivery sites are going to want to have programs available where their members are and when their members want to have them. Next slide. One of the other key components is partnerships. States have built extensive partnerships with groups that you would expect and some that are pretty unique in order to reach the target audiences. Next slide. Here are some of the organizations that states are working with. In terms of working with disability advocacy groups or support groups, the NCOA has a tip sheet that was just recently put out. It's called Chronic Disease Self-Management Education in People with Disabilities. It has some really good ideas, and it's a compilation of different practices from a number of states in terms of working with people with disabilities. The Aging and Disability Resource Centers can be implementation sites and also referral sites. They can help to integrate CDSMP into community-based care transition programs and also their option counseling programs. In Alabama, about half of the family caregiver support programs are integrating the chronic disease self-management education for their caregivers. In terms of reaching people in rural areas, the National Council on Aging recently put out a tip sheet on CDSMP and people in rural areas. And we also recently had a webinar on Wisconsin's experience in working in rural areas. In Massachusetts, the enrollees in the Senior Community Service Employment Program go to the Chronic Disease Self-Management Program as part of their training. Some of the more unique partnerships that we've seen around the states are with libraries, YMCAs, YWCAs, rural organizations, hairdressers, local restaurants, post offices, bowling alleys, and schools, because schools become a focal point in many communities, especially the more rural ones. Next slide, please.
Okay, this is Cora, and I'm going to pick up here and talk a little bit about healthcare partnerships. Here you see a list of various types of healthcare organizations that our state grantees and other partners are working with. And with the Affordable Care Act, there's lots of opportunity with these various health systems to look at working with them and actually receiving reimbursement or payment for the services that you provide for CDSME, because payment now for these health systems is based more on value versus volume. In the past, the focus was on volume or a fee-for-service model. That's going away, as you all know, so there are opportunities for providing CDSME and benefits to these healthcare organizations. Next. So of the grantees that we have now, the 22 grantees, most, if not all, have built some partnerships with healthcare. Everybody's at a different point along the continuum, and we're all learning together about what works and how we can better integrate CDSME with healthcare. Here are a few things that are happening across the country. Some health plans or national insurers have a core mission to improve health outcomes through health promotion and education efforts. And there's a direct benefit to those insurers, again, because they're getting paid on value. So if they can show better outcomes, they can reduce costs. And besides improving the health for the individual and the health care, it lowers the cost and puts, I hate to say, but puts more money in their pocket. So it's good for them, it's good for the patients, it's good for everybody. The accountable care organizations, we'll talk a little bit more about that in a few minutes, but there's an opportunity for shared savings among those involved with providing services through accountable care. So again, they have to show quality, and that can help to lower their costs and provide them a higher level of reimbursement. So with the Affordable Care Act, there are lots of opportunities, and prevention and health promotion is becoming much more of a focus because everybody is recognizing the benefits that it provides to achieve the triple aim goals of better health care, and lower costs. Some health plans are also providing financial incentives to their members to complete CDSME program. Next. So I think everybody knows the benefits of CDSME if you've been doing this for a while, that there have been study after study that shows that people have better health, mental health, physical health, self-reported health, reduced health care utilization, that CDSME helps to achieve the triple aim goals. But I think a lot of times we forget about that it can also help increase customer satisfaction. And customer satisfaction is very important to healthcare organizations because it promotes their sales and profitability. So when people go to CDSME, they tend to be more excited about the care they're getting. They feel positive about it, more in control of their health. And it also provides a framework for interaction between that patient and the members of the clinical team, not only the doctor, but also other members. Also, if staff in the healthcare organization are helping to offer the program, they get a sense of satisfaction because they're seeing the positive changes in the patients that they serve. But generally, someone who's a CDSME graduate is a loyal customer. They're going out and telling other people about the great program that they attended and how it helped them. So it's just something to think about that I think many times we forget, and something that you can share and discuss when you're talking with healthcare organizations. Next. So here are a few of the Affordable Care Act healthcare transformation models. We mentioned accountable care a few minutes ago, but these are groups of providers working together. So rather than have the small doctor's office like we used to have, many of these offices are now working together, and they are providing a high volume of care, but in order to get paid, they have to show that they're providing a certain quality, and they have to show that they can lower costs. And as they're able to do that, their quality and lower costs to get good health outcomes, there's a shared saving among all these members of that accountable care organization. Patient-centered medical homes also present a great opportunity with the certification standards, care coordination, and self-management education, as well as community resource referrals are core components of those standards. So now when you're working with a patient-centered medical home, you can say, well, by offering CDSME, you're going to meet that self-management standard. And also they have to show that they're referring people into programs. So if you're an aging network organization offering the program, there's a benefit to that patient-centered medical home to refer, because they have to show that they're doing that. And the federally qualified health centers now are all becoming, either are becoming or have become patient-centered medical homes. So that offers an opportunity to work with them. And they're great organizations to work with because they're working with underserved populations. And as we're trying to see that CDSME gets to the people who need it most, federally qualified health centers would be a great healthcare partner. Care transitions programs, I think everybody's familiar with them, and generally the AAAs are involved in the care transitions, working with hospitals to see that when the patient leaves the hospital, that they're getting what they need next to be able to stay at home and to prevent a hospital readmission. Hospital readmissions are very costly to the hospital, and it's very bad for the patient. So the care transition program is an opportunity, again, to offer CDSME, because if a person can learn to manage their health, then they're more likely not to be rehospitalized. And so Mary is going to pick up here.
Yes, and most states have a centralized or coordinated processes, and they find that is very helpful as they build their programs out into a larger area. Some of the things that states do in their centralized processes is they may have a statewide website that lists the workshops and training opportunities. They may have a statewide toll-free number. They're able to put out annual state and county level data reports, and they can do presentations and technical assistance to support the program statewide, as we're doing this morning. Having those centralized processes really help in terms of marketing and recruitment, finding referral sources, the reporting, and also for fidelity, which is an essential part of all of these programs. It also helps to have a statewide, oops, we're going back and forth. It also helps to have a statewide name, because then people in any part of the state will recognize that they're dealing with the chronic disease self-management program. As states move to integrating CDSMP into other programs and funding streams, the centralized process also help with these. There are efficiencies for providers and payers. There are economies of scale when providing training or other resources. Marketing becomes easier because you can have a marketing program that reaches a number of people throughout the state. And also there's fidelity to the Stanford model, which as you're working with other providers and funders, they're going to be looking for that. That's a very important piece. Next slide, please. Some states have found it helpful to go to a hub or having an institute to kind of organize those centralized processes. Some states as examples are in Massachusetts, New York, and Wisconsin. They all have institutes which are involved in training for master trainers and leaders, and also they do a lot of the marketing. They can do billing as you're moving to more of a payer system. An institute can be responsible for billing and coordination with other evidence-based programs. They can have statewide messaging, and they can also do statewide training. Another key point is that a not-for-profit institute can apply for grant funding on behalf of their partners that a state organization might not be eligible to receive. Next slide, please. Cora?
Okay. So business planning and financial sustainability is very important in terms of sustaining your program long term. And some things to think about. They sound like elementary questions, but they're really complex. What is it that you want to sustain? And if you're moving from grant funding to not being funded by a grant, there may be some decisions you have to make in terms of how you're going to best utilize your human resources as well as your financial resources to see that you can continue to sustain the program and hopefully to grow it. Some things to think about are leadership. Hopefully you have that collaborative leadership, and how can that continue? What commitment do organizations have to the leadership of the program? Staffing, thinking about training of leaders and staff within organizations as well as volunteers, leaders and trainers. You've got to have that infrastructure, of course, to sustain the program. Partners, who's going to do what, who's at the table, and who's committed to keep the program going. And I don't have mentioned here, but when you're thinking about partners, also thinking about marketing, who's going to do that? Just offering the program is not going to make it work. You've got to have some good human resources and finances around marketing it, and then looking at what that's going to cost. We do have a cost calculator on our website, and so you can actually go in, it's a spreadsheet, and put in how you're implementing the program and then get your cost. That would be very important to do as you're thinking about working with healthcare and potentially having a contract with healthcare for reimbursement and or payment. Next. So we do have states now, which is really exciting, pursuing reimbursement for CDSME from Medicare, Medicaid, and other health plans. Again, everybody's at a different place along the continuum, and it changes every time we hear from our state somebody is doing something new. So again, we're all learning together, and we here at NCOA are working to capture all that so we can share that with you all and others so that you can learn from one another. We've mentioned already about the Affordable Care Act, and we've talked about patient-centered medical homes. Patient-centered medical homes and all of these healthcare systems, besides being an avenue for reimbursement or payment, can also help to get patients, their patients, into the program. So it can help you build that participant enrollment, because sometimes that's one of the biggest challenges of offering the programs. Next. So other reimbursement opportunities, these are 3 opportunities that are underutilized right now, and we are providing technical assistance to help more partners to be able to get reimbursed under Medicare. So these are all Medicare benefits. The HBAI, the HABI benefit, is actually a psychosocial benefit under Medicare that a lot of people aren't aware of. But the benefit is designed to help people who have barriers to achieving their health care outcomes to receive services so that they can better meet their health care goals and follow their plan of care. And CDSME, when added to the appropriate infrastructure, appears to meet those requirements. We're going to start a learning collaborative for some states that are interested in being able to get reimbursed under HABI. So we'll just be beginning that process, but I think it's exciting. And Tim McNeil, who's the subject matter expert, will be helping us to guide states around that with the goal of getting reimbursed. I think everybody's familiar with diabetes self-management training. We have a lot of resources on our website about that, but that is using the Stanford DSMP program to be accredited for DSMT. And that DSMT accreditation and service allows you to get reimbursed under Medicare, Medicare Advantage plans, many Medicaid plans, and also other health plans. DSMT is a benefit that is widely used in healthcare. So this is a great opportunity. We have a few states that are doing this, but more and more are interested in working toward that as a goal. It is a rather rigorous process, I understand, but we will also have a learning collaborative around that to help states to be able to achieve that goal. Another benefit under Medicare is medical nutrition therapy. These services are used for medical nutritional assessment and counseling, and CDSME programs can be a secondary billing mechanism under medical nutrition therapy. So in order to use this, you have to have someone who meets the criteria to provide the nutritional assessment, counseling, and group counseling services. But many of the aging service providers do have a registered dietitian on board. Next. So some of the considerations when you're thinking about business planning is thinking about which healthcare organization you might work with. You probably, I always say, start with a low-hanging fruit. Who do you know already? Which type of organization do you think offers you the most potential? And sometimes starting with some organization that you already have a relationship is a lot easier to do, because maybe they already know about the good work you're doing, and now it's just taking it another step to see how you can work more as business partners. Finding a champion with an organization is always an important and helpful way to get buy-in to the program by the organization. So if you know someone, that's a good place to start, but you want to be sure that you get the buy-in of the leadership of the organization. It's important to think about how you are going to articulate your value proposition. And what that means is really thinking more about what you have to offer as a product and how can it benefit the healthcare organization to help that organization to achieve their goals. So framing it up so that you have a script. When you go to the healthcare organization, you know what it is you are going to say, and you say it succinctly. Thinking about a shared risk as you get started, because you don't want to take all the risk yourself, and a lot of times a healthcare organization getting started may not either. So you can share that risk in terms of, we believe in this program, and let's do this together and figure out how we can do it to make it work, because we realize it's a good program that can really improve the health care for large numbers of people and improve health and lower cost. And forging partnerships with other CDSME providers to respond to the need, or forming a network, has become a very popular way of being able to meet the need when you work with a healthcare organization. Because if you're working with a large healthcare plan, for instance, that covers the state, and maybe you only have services in a certain area, you'll want to be able to meet their need. And they don't want to have 10 contracts with 10 different organizations. So look at who else you can work with, how together you can then approach the healthcare organization and develop an agreement, and maybe an MOU to start, then a contract, but beginning to build those relationships toward a contractual relationship. You want to think carefully about recruitment and referral. I think sometimes everything is done and then this is kind of put on the back burner, and it really needs to be put on the front burner, because just having the program available doesn't make it work. And a lot of times the healthcare system will tell you, oh, we've got thousands of people to send, but it's not that easy. There has to be a very thoughtful process of letting people know about the program, the benefits, and getting them into the workshop. Thinking about quality is always important, because nobody wants to be involved with a program if they don't know that it's going to get good results. And if they don't see the quality. So you want to make sure you have good fidelity monitoring and other measures in place to look at quality. And you want to think about your data collection too, how you're going to show quality and how you're going to show results, what it is that you're going to collect and capture. Then you'll be in the process of developing the contract and taking it a step at a time, because when you look at all this, it can sound overwhelming, but remember, Rome wasn't built in a day. It takes time, and just take one step forward. You don't have to have all the answers to just keep moving forward. Next. Okay, quality assurance should be next.
Well, first, let me.
Sorry. Maybe she stepped 2 steps ahead.
Yeah,
okay.
I'd like to share just a few. I'd like to share just a few ideas from states around sustainability and what states are doing. In some states, the CDSMP has become part of an employee wellness plan, especially among state employees, which is a good way to get it out to a large group of people who could really benefit from it. United Way or other community giving employee giving campaigns is a way to get some additional funding. In Washington State, one of the area agencies solicited 43 local businesses to donate workshop supplies, which greatly expanded what they were able to do. And just as a reminder, with the Old Americans Act, Title 3D, beginning on October 1st, 2016, the 3D funds will only be able to use to meet health promotion programs to meet the highest level criteria. So if there are area agencies that are using the Title 3D funds for programs that don't meet that criteria, by this time next year they will be required to use them for programs that meet that highest level criteria, and of course chronic disease self-management education is in there. Foundations may be a source of funding. We've talked a little bit before about funding through the Centers for Disease Control. Also, HRSA is a possibility. And there are state and regional level grants that are available in different states. In California, there is a clinic that got a foundation grant for $10,000 towards leader training, stipends, and material. And the Area Agency on Aging Association in Michigan received $5 million from the Michigan Health Endowment Fund to expand DSMP and a matter of balance. And all 16 area agencies in Michigan have received that funding. So those are just a few examples of some of the creative funding methods that states have used. Cora?
I've already mentioned the importance of quality assurance, and as you think about quality assurance, like other things, it's important to have a plan and a process in place statewide so that you can assure wherever programs might be offered in the state that they're going to look the same and that you can assure quality. This is really important as you think about long-term sustainability and particularly working with healthcare organizations, funders, and healthcare. Anyone who's going to consider paying for the program wants to know that the program's delivered with quality and fidelity. And we do have resources on our website. Here are a couple that are available, and we'll talk about more in a few minutes. Next. So our website here at NCOA has lots of resources to help you to make your job easier. And if you'll go to our Center for Healthy Aging homepage, which you'll see there at the top, ncoa.org/CHA, this is what you see. We have the National Falls Resource Center and the CDSME Resource Center, both funded by ACL, at the bottom, the 2 bottom buttons, and then at the top a little bit just about our center overall, and then the top right button, offering evidence-based programs. For CDSME, the 2 buttons on the right, the one at the top, which is general about offering evidence-based programs, and the one for the Resource Center, are 2 areas where you'll find lots of resources to help you sustain the program. So let's talk a little bit more about that. Next. So if you click on that button that says Offering Evidence-Based Programs, you'll come to a page that looks like this. And you'll see that we have information and resources about program planning, which includes the community toolkit. We have information about program implementation, outreach, evaluation, and then you don't see it because we just couldn't get all of it on the page, but there's a sustainability button there at the bottom too. So any of these elements that you want to learn more about, not only do we have our resources posted there, but we have a few examples of some of the state's best practices in each of these sections. And we'll continue to add new resources to this, particularly those state examples, as we learn more from states and get some good resources that could help others. Next. When you click on that sustainability button on that page that I just showed you, there are lots of resources for sustainability, but particularly we have an issue brief that covers those elements that Mary showed you on the slide earlier in the presentation, and it gives you a little bit more detail about each of those elements for sustainability. We also have a training module, which is really great, so you can just listen in and it will walk you through step by step what you need to do to create a business plan. So I think that can be very helpful. Also, we have several sustainability and business plans from states that we think would be helpful to others on our website. So if you're not sure how to go about it, you can look and see what some others have done, and that maybe can help you think about how you would develop your plan. Next. We also have on our website a section on community integrated health care. This section is found within the center, the CDSME Resource Center. So the button that says CDSME Resource Center, when you click on that, you will see the community integrated health button. You'll click on that and it brings you to this page. In this section, we have a lot of information, toolkits, facts, tip sheets, webinars, sample MOUs, etc., about community integrated healthcare. A lot of resources, particularly about DSMT, but also some that are general to CDSME programs. Next. Oh, we got disconnected. Whoops.
I think we're still there. It was just one person disconnected.
Oh, can you hear me?
Yeah, I sure can.
Oh, okay, good.
It was only one person dropped off.
Oh, okay, great.
We're
saw
good.
Something, heard a sound, and I
No,
thought
we're fine.
Okay, so also we have, in addition to our resources on the website, we have online communities that are really underutilized. So as in the coming months, we're going to be starting some conversations around various topics, and we encourage you and others to do so. We have a healthy aging listserv and also a listserv or online community for DSMT. So if you're not a member already, you can join either or both of those listservs. And if you have a question and you want to talk to some other states and hear what they've done, you can just post the question on the online community. We also have a Center for Healthy Aging e-newsletter that we encourage you to sign up for if you haven't already, and that is posted on our website. So there's a place that's very easy to see on our homepage that says sign up for the e-newsletter. We also have a resource library where you can search on any topic and find lots of resources. So please feel free to, go on our website and look around. We're continuing to add resources, continuing to refine our website. And if you have suggestions for us, things that you would like to see that are not there now, let us know, because we're wanting to meet the needs of our partners across the country. We want to be able to provide the support that you need so that you can be successful with scaling and sustaining CDSME. Next. And so that concludes our presentation, and as Mary mentioned earlier, and I just wanted to reiterate, here at the Center for Healthy Aging and the CDSME Resource Center, we are available for technical assistance and support to any state or community-based organization that's offering CDSME programs, not just the grantees. So we really want to be available to you to provide any support that you might need to help you to continue to do the good work that you're doing in Colorado. And I do want to say, I know Colorado's doing some good work with federally qualified health centers in particular, and we're excited to hear of what's going on there in Colorado, and also, you know, always eager to hear what you're doing next. Lots of good work, and I know Lindsay in particular, we've had lots of conversations with her about her referral feedback loop that is provided for physicians and the database to be able to track who's getting in a program and how they communicate with doctors. So you have some of the leading partners right there in your state. We have many other wonderful partners across the country. So thank you for inviting us to present, and we're available to answer any questions that you might have.
Thank you, Cora. Thank you, Mary. Who has a question?
This is Connie. I'll chime in with a couple questions, but to start off, I thank you so much. This is just a wealth of information, and you've worked really hard to pull together way more than I expected, so thank you so much. I was curious on the states that have started, like independent nonprofit organizations or institutes that kind of champion the cause of CDSME programs statewide. How have they funded? How are they funded on an ongoing basis, as well as how were they funded for the startup period?
And I don't know a lot of particulars about that. Mary, do you know? I think in some cases, and sometimes they've had grants and various sources of funding. I think sometimes they've been funded maybe under the ACL grant to start. But they do have other sources of funding now. I don't know the particulars. And Mary, Michelle, or Teresa?
Yeah, this is Michelle. It's my understanding that most of them have been, if not all. I know Massachusetts and Wisconsin, in particular, they used the ACL grant funds to help start it. But in both cases, they've received other funding as well. Massachusetts received a large grant from the Tufts Foundation to help build the statewide hub structure. So, in having this institute allowed them to, it was easy to go outside the state government to get this additional funding.
I will say, too, that it appears that more and more states are interested in that concept and are moving in that direction. I know we just had a phone call with Maryland, Mac Inc., and they're working towards building this hub, and I've heard some other conversations about that. So it does seem like a model that works well, and more states seem to be looking at that as an option.
Oregon is also just going to a hub model. They've just released their RFP recently.
Okay. Okay, thank you very much.
Who else has a question for Cora or for Mary?
This is Whitney. I have a question. So does anyone know if there is a list anywhere or somewhere we can figure out which providers are accountable care organizations and which are patient-centered medical homes, that type of thing, so that we can tailor our language to what they're looking for?
I think from state to state, you probably need to look at who's a patient-centered medical home or a accountable care, et cetera, because it's going to vary across the country. But the question about having a particular value proposition that you present, say, to a patient-centered medical home versus an accountable care or some other organization might be different. So we're working now on some resources to provide that to you. And there is, I don't know that there are specific scripts for different types of organizations yet on the Business Acumen Learning Collaborative site that's on the ACL website. But anyway, that's something that we're working on. I think it's a good question and something that we need to pay attention to because it probably needs to be couched a little bit differently with different organizations. Again, Michelle, maybe you have or others have something else to share about that.
This is Mary, and I would recommend you talk with your primary care association to find out about FQHCs and patient-centered medical homes.
But there can be also the private patient-centered medical homes, and I'm not sure how you would find out beyond the FQHCs who they are in your state.
There is a way you can search for them. If you go to the NCQA website, you can search by state or even by zip code to see who in your neighborhood has applied, at least through the National Committee for Quality Assurance. And that'll
that's good.
That'll get you a start, at least, Whitney. Then the other piece is you can also take a look at, if you Google ACOs in your area, they all include a hospital. So it's a good way to start with your local hospital. Google them and find out which ACOs they're associated with, and that will then lead you to which practices, which hospitals. And I think what Cora and Mary are saying about the value proposition, a lot of the terminology is going to be the same because it's all about the transformation work, and it's all about self-management support. So you can use very similar terminology with all of those different organizations.
And we do plan to have a website, a new resource soon on federally qualified health centers, which will also include patient-centered medical home information, since the FQHCs are patient-centered medical homes. Hopefully that'll help you. And I'm not sure of the timeline on that, but we're thinking, you know, in the next month we'll have that available.
Yes, thanks. Good questions. Who else has a question?
Go ahead. Sorry, Connie. Go ahead.
No, you go ahead. I'll come back later.
No, you can start. I'll come back later.
Okay. I just wondered, as Cora and Mary were talking about the learning collaboratives, and I talked with one of, I think it was Cora, told me about those before, related to the HBAI, the Health Behavior Assessment Intervention, and also the diabetes self-management training. And are you still thinking of starting those sometime this fall, or do you have a rough timeline on that?
Yes, we're planning to start them as soon as possible. What we're doing now is, as we're having the kickoff calls with new grantees, we're finding out what their interest is, and then we're also, in the meantime, developing some parameters around how would we manage these collaboratives. So we plan to get them started. I think we can get them started in October, certainly no later than November.
Okay, and would we be able to invite as many people as are interested in Colorado?
Well, we do have a limit, so probably what we'll do is offer it to like one person in the state, who then would be the contact with the other people in the state, and then that information could be shared within your state and you could work together. But likely just one person per state on the actual collaborative, just because of we don't, you know, we want to keep it small enough that there's opportunity for interaction and sharing.
Sure. That'd be great. I don't suppose if there ever were a chance to record them, that would be great, but I don't know if you all have that capability. But I'm excited about those because we've Various people have had some interest in both of those in Colorado, and Cora, you mentioned to me at the conference that that was one thing that would be, the HBAI was something you thought, as you said today, is underutilized and maybe less time-consuming than some others, just for starters. But anyway, I'm looking forward to those opportunities.
And we'll keep you posted.
That sounds great. Thank you.
And there was another question.
That was from, go ahead, that was from Ellen. This is Ellen, and I just kind of had a general question, and maybe you can kind of guide me. But typically we've been offering programs to the community, you know, free essentially, because we've had grants and the state has been very generous in supporting us and things, but of course that's going to be going away. So a lot of these folks, especially like the physician groups and things, just assume that we're going to continue on and they're going to continue to use our classes, but we're not getting anything back from them. And so like the diabetes, so they might be able to get reimbursement for that, but how does that contract work if we were to say we would like to keep providing this, but we need your support and you can get reimbursed for it? And so how have you seen how that works?
You mean that they can get reimbursed in working with you? I'm not sure exactly what you're asking.
Well, because right now we've been offering it free of cost to them essentially, to any of their physician groups and things, but as because they're part of the Primary Care Initiative program, so they can get reimbursed for some of these things, but they don't feel like they need to because we already provided to the community, because we've been very fortunate to have, like I said, the state provided some and we had some grants, but that's kind of the sustainability part of it. It's so, you know, because they can get reimbursed for it, but then we don't get any of that benefit. So how do you work out that contract? Have you seen that contract?
I think that would be starting the conversation, so letting them know what your situation is in terms of funding, and that you would not be able to continue to provide that, but also helping them to see the benefit. But, you know, we have this great opportunity. We want to keep this program going, the benefits to them, and then thinking together about how you could partner and how you could make it a win-win for them and for you, so that they're not looking at it as they're losing something, but they could see they could gain. Maybe they could even expand the program further to their consumers if you work together more collaboratively and look at opportunities for payment and reimbursement. So I think getting the conversation going and thinking about who's the best to engage in that first conversation and how you might approach them, and be sure that you think through, you and whoever else might be part of that initial meeting, how you're going to approach this. But I'd say just get the conversation going, number one, and you don't have to have all the answers, but working through it together and actually inviting them to be a partner so that you can keep the program going and even expand it to serve more people.
And this is Mary, and I'd like to just offer, too, that this is a question you might want to pose on the Healthy Living Crossroads website, because I know I've heard other states mention this concern as well. And I think you might be able to find some learnings from other states if you posted a comment on the website.
Okay.
Great idea.
All right. Thank you.
I also think one of the things that we have learned is that sometimes you have to start with sort of tiered levels of support when you're going from something that's been totally free to a practice to needing their support. So that's where that whole risk sharing proposition and that value proposition that Cora and Mary were talking about can come in and be helpful, so that in a way you're weaning the practices off of the idea of everything being free and slowly moving toward them paying for the program. So it may take several classes to make that transition work. Any other questions?
Great, thank you.
Any other questions or comments from any of our guests today, from Cora or Mary, Michelle, Teresa, anyone else that's on the line?
This is Mary. I'd just like to say thank you for giving us this opportunity. I think whenever we do something like this, we hope that you learn from us, and we know we always learn from you as well.
This is Connie again. Do you have a sense from your interactions with people whether there maybe are 2 or 3 of the strategies that you mentioned that you think have been most successful? I know when I queried some people about Medicaid, and I guess primarily Medicaid as part of our sustainability outreach background research, and you know, there were some that have been successful in one thing or one strategy or another, and others that had tried, but it hadn't worked out as well as they thought. And I'm not just focusing on Medicaid, but I just wondered if you had some kind of big picture ideas of, like, these are some of the top 3 or 5 partnerships or models that have been most successful, or?
Well, I think it might be unique to each state and who the partners are and what relationships are already established, because many times the state and community-based organizations are building off partnerships that they already have. They've had these relationships. But I'd say one of the key partners that I think every one of our 22 states are working with are the federally qualified health centers. So there's always been a good relationship with federally qualified health centers and the health department. And so since the health department and aging have been working together, that to me is like an organization that's easy to approach. And they fit in that patient-centered medical home model. So there are probably already some existing relationships that can be built upon there. But with that said, again, looking at where you are in your state and where you think you might have the best opportunity for success. I will say hospitals might be another one. And Maryland is doing a lot of work with hospitals, but there's a big push to prevent readmissions. So hospitals are really now stepping up to the plate, and they're having funding coming from state Medicaid too for those the patients that utilize the emergency room and have hospital readmissions. They're getting an incentive or a payment model from Medicaid to reduce those readmissions and keep people out of the ER. So there's certainly a lot of work around that, and generally that also involves the state Medicaid agency. But those are a couple ideas I have, and I'll ask for others to share their ideas.
We talked in the beginning about the partnership between public health and aging, and I think that is a prime driver for the sustainability of these programs. Aging has their 3D funding, which is it's not a lot, but it's a consistent source of funding. At least it has been in the future. I hope it always continues to be. And the departments of health have funding through through CDC, that a lot of it is targeted to things like chronic conditions. And there are a lot of places where CDSME can be integrated into that system as well as the aging system.
Okay. And who was that just talked?
Oh, this is Mary, sorry.
Mary, oh, that's okay. So, and that was Cora right before that, I assume. We do have the good fortune, I think, in Colorado to have good partnerships both with Medicaid and public health. Kelly McCracken was on the call earlier. I believe she had to sign off, and Katie Mortensen from our Colorado Medicaid office was out of town or unavailable today, but they've been part of the process all along, and we did get some good information as part of that sustainability planning research that a couple people from Medicaid, Colorado Medicaid, were interviewed, and they had several good suggestions. So I think we're at a good point to pursue more of those as time goes on, and then the health department has also been really successful in sustaining, getting new revenue streams for some of their more prevention-oriented programs. So as we move forward, we hope that we will be able to get some guidance and suggestions from public health on how to best do that. And just as an FYI, we have, since I work with the state, and the State Unit on Aging, and which is oversees the area agencies on aging. We and several staff here have reinforced the requirement to shift the Older Americans Act Title III-D funding for evidence-based programs that have that have evidence behind them. That they work, and so I've made presentations at our AAA meetings about CDSMP several times, and so the only downside, as I think Mary just said, is that there isn't as much funding as that as I would like, but we are keeping it on the radar, and there are several that are already prioritizing that, and we hope that will increase over the next year or so as well. So thank you for those suggestions. Oh, I did have one other question real quick. On the hospitals that you mentioned, Cora, and the care transitions programs, we had two area agencies on aging that had federal contracts with CMS to launch the care transitions programs, and that my understanding that neither of those still have funding for that. To me, it seems like it would still be, we'd be able to be successful with hospitals just for the reasons you mentioned, that doing this kind of program, even if they were paying the small amount that the program costs, it would save them on the other side, the flip side of having to readmit people and then having issues come up with CMS, because I know CMS is concerned about that. Anyway, I'm just wondering if if other states have been able to persuade hospitals of the benefit of providing CDSME programs and funding those as part of their care transitions programs.
No, I'd have to look to, I'd probably get back to you. I don't know if Mary knows off the top of her head or Michelle. I'm sure there are those, but I don't know specifically which states are working with the care transitions. Michelle has, she develops every year a summary of the progress, and I can, on our website in the grantee section, at the very top of the page, there's a report. So it's probably in there as to what states are doing. And off the top of my head, I'm not sure.
Yeah.
Specific states, but we could get back to you on that.
Okay, sure. Yeah, and I just was trying to, I guess it would be one of those other strategies of developing messages specific to hospitals on the value of funding these programs and saving themselves money on readmissions and that, and improving quality care, et cetera. But anyway, thank you.
And I'm also going back to thinking of what Mary's response was previously. If you want to post that on the Healthy Aging listserv, that would be another way to find out who's doing what. But we can share what we know, and then possibly you would want to do that, and maybe some would respond.
That sounds good.
I just looked it up, and 3 states reported receiving some funding for CDSMP through their care transitions programs. Those are Massachusetts, Michigan, and Missouri.
Okay, thank you.
You might also check with Virginia. They're doing some work with care transition as well.
Okay, great. Sounds like somebody's moving furniture in the background.
It does indeed. Does anybody have any additional questions or comments for Cora or for Mary? Well, I just want to say thank you both again, and thank you for joining us today. I know we have a couple of other agenda items, but I also know we're a little tight on time. So Connie, since I know Mary Pat had worked with you on setting the agenda, so I will let you walk us through what else needs to be covered in today's collaborative call.
Lindsay, Connie, and everyone else, thank you. I'm going to go ahead and sign off then. This is Cora. Thank you so much for the opportunity, and let us know if there's anything else we can do to help.
Yeah. Thank you both so much. Thank you also to Teresa and Michelle for your support and leadership. They probably are just gone, but they both have been very helpful.
Okay. Thank you.
I don't need to say a lot. I did send the online class link yesterday, so if anybody has any questions about that, please let me know. Also sent out our sustainability planning document. It's not quite a plan as I had initially envisioned, but I want to maybe we'll do part of this through email to figure out or suggest a couple options for where we go from here, and two that I have in mind are, and we've kind of talked about before, is having an in-person meeting where we would all kind of come together and say, okay, here's the background research, here are the recommendations, paired with the information we got today from NCOA, what are our first steps in pursuing this, and we may be able to can do some background work on that ahead of time to get us moving. The other thing I'm interested in, it probably would be good to query people via email, is your interest in having, it might be a separate or combined meeting where we would get people to present, people from Colorado, like COA, like Department of Health, and some others on other additional strategies that they have used in Colorado to get new funding streams for CDSME and give guidance and ideas for everybody else and how you can do that locally. So we don't have time to go into all of that more now, but I will send out some information and work with Mary Pat about that so we could get some background and discussions going for the next call.
Great, and we will get the link for the online class. Will be up on next week on the collaborative website. And I'm just going through real quickly the rest of the slides. Then we have just a couple of trainings that we know about. If anyone else has trainings they want us to be listing, send them our way, and we will get them on the collaborative website as well as on our next meeting date. I know the agenda for next month is Renee Callanan from CDPHE, and I believe Kelly's already dropped off the call, but as you can see here, it's regarding chronic disease prevalence by geography, by age. And anybody want to say anything about the agenda for next month?
I think this is going to be great overview of that, and maybe provide some data for people to use in local outreach efforts on just showing the need and demand and of it for chronic disease support, and in contrast to what's available. So I think it could be beneficial to everybody.
This is Glenda, and I just want to say that I find our meetings to be very productive and informative, and I just want to thank all of you for the efforts that you've put into bringing this information to us each month. It is just invaluable.
Thank you. Thank you. I will pass that along to Mary Pat, too.
Okay, thank you.
Okay, folks, so the next meeting is set for Thursday, November 5th, 9 to 10:30. Same numbers. Hopefully everything will be much calmer on the GoToMeeting site next week and next month. So we will have, we'll edit together as best we can the session that we did today and try and get out the pieces that were the false starts when we had technical difficulties. And then the recording will be on the collaborative website, probably by Monday.
I think we recovered well from that the technical difficulty.
Yeah, we've never. Thank you. We've never had it
No,
go
of course
down.
not.
We've lost audio and we've lost the webinar, but we've never lost both, which makes me think it was a glitch on there, and they must have had some sort of a surge or something that just disconnected everything from GoToMeeting. So sorry about the inconvenience.
No problem. We worked it out.
Yep, we did. Well, if no one else has anything, we will go ahead and stop the recording and end the meeting.
Thanks, Lindsay.
Thanks, Connie. We'll talk to you guys soon. Thanks, everyone.
Thank you, everyone. Bye.
Bye.